Hypertension Awareness Series Episode 21. Choosing the right antihypertensive drug, drug selection based on comorbidities and compelling indications. Good morning and welcome to today's episode. Please note this is also a technical presentation targeting those who manage hypertension. And today's focus goes beyond lowering blood pressure. It is choosing the right drug to treat the patient, not just the numbers. Just a reminder, our core principle still remains. The four classes of drugs that we use initially are still the same, and the main classes that you choose from are ACE inhibitors, ARBs, calcium channel blockers, thiazide or thiazide-like diuretics. They remain foundational, and combination therapy is still the principle from the word go. The only difference is that now you shift from which drug to use to which drugs benefits this patient most. So let's discuss the common comorbidities with hypertension and choice of your antihypertensive drugs. We start with heart failure. For those patients with heart failure and hypertension, the preferred choice still remains your ACE inhibitors, your ARBs, your ANI, beta blockers, and MRAs. These reduce mortality and prevent hospitalization in heart failure. Remember, in heart failure, you avoid your non-dihydropyridine, calcium channel blockers like verapamil and diltiazem. Nifedipine should also not be used in heart failure. The other comorbid, which is very common with hypertension, is diabetes. So for diabetes, kidney protection becomes key. So your number one choice is ACE inhibitors or ARBs. And this is because they offer renal protection and reduce proteinuria. You can also add a CCB or a diuretic. So your initial combination therapy in a patient with diabetes can be losartan plus amlodipine, losartan, HCTZ, or even enalapril, but you must include an ACE or an ARB. The comorbid number 3 is chronic kidney disease. For those with CKD and hypertension, your number one choice is ACE inhibitors or ARBs. And this is because ACEs and ARBs slow CKD progression. Remember to monitor your potassium and your creatinine. And if needed, you can add your diuretics in kidney disease because of fluid retention. We move on to ischemic heart disease. For the patients who are post-myocardial infarction, your choice remain your ACE inhibitors or ARBs and your beta blockers. You can add on CCBs if needed. And this is because this class of drugs reduce your myocardial oxygen demand and can improve outcomes post-MI. What of patients with hypertension and stroke? So for those with stroke or TIA and hypertension, your preferred choice is ACE or ARB plus thiazide-like diuretic. And this is because there is strong evidence for stroke prevention if you use ACE stroke ARB plus thiazide-like diuretic. In the other class of the elderly patients, we prefer long-acting CCBs plus thiazide or thiazide-like diuretics. And the principle in the elderly is to start low and go slow. Avoid overtreatment because the elderly have higher risk of orthostatic hypotension and they can present with dizziness or even syncope. So for an elderly patient, CCB or a thiazide-like diuretic. What of the black population? In the black population, the choice remains CCB plus thiazide-like diuretic. I talked earlier about the Creole study which was carried out in sub-Saharan Africa. And this is because the hypertension in blacks is low renin state, salt sensitive hypertension. So choose your CCB or thiazide-like diuretic. However, if the black person has CKD, diabetes, or heart failure, the other drugs are also chosen. What of pregnancy? For pregnancy, you are safe now. Here we use different medication from the four classes. Your number one choice in pregnancy is labetalol. Your other options are nifedipine or methyl-dopa. Please remember, ACE inhibitors and ARBs should not be used in pregnancy. So safe choice in pregnancy, labetalol, methyl-dopa, nifedipine, and we also use hydralazine in pregnancy. So remember, those comorbidities guide you on the drug to choose. However, combination therapy from the word go. Remember, you do not combine ACE plus ARB inhibitors. ACE, ARBs are avoided in pregnancy, and then calcium channel blockers, verapamil, diltiazem, nifedipine are not used in heart failure. The main principles still remain. You use 2 drugs from the word go, but you combine based on the BP level and also the underlying condition. Please note, even in the source-limited setting, the principle still remains. Control your blood pressure and match your drug to the disease when possible. But note, sometimes you don't have all those options. Start with available agents or prioritize BP control and adjust when needed. Hypertension is not just about numbers, it's about selecting the right drug for the patient. And when you choose wisely, individualized therapy, you treat the whole patient, and the key is to prevent complications. So do not miss our next episode when I discuss about BP targets. How low should you go? As always, Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.